Ladies and gentlemen, good morning, Khaima to be precise. Today is the 19th of January, and this is our third Obefit webinar. A health syndrome. Obesity, a health syndrome, is our topic. We normally believe that obesity is a consequence of eating too much of food and having too little activity. That is what we generally believe. As I always do, I was reading up last night about today's webinar, and I came across some interesting statistics. I discovered that 40% of obesity had a genetic or a family-related environment. I also discovered that 44% of obesity had some form of medical correlation. So therefore, my earlier belief that obesity was largely a matter of simply eating too much of food and doing too little activity began to undergo some change. I decided that since we were having an endocrinologist speaking with us or to us today, I decided to read up on the Endocrine Society's preferences or attitude or policy towards obesity, and they gave me three clear causes. They said obesity to be managed, all the causes come by and large from lifestyle, medication, and the solution is obviously lifestyle-related change, medication, and surgery. So the Endocrine Society gives us three solutions: lifestyle change, medical solutions, and surgical requirements in extreme cases of comorbidities and a BMI of above 40 or 50. They also mentioned that more than 44% of obese individuals had some medical correlation, but only 10 to 20% actually consulted a doctor, which left the large population of individuals who are obese with comorbidities, hypertension, diabetes, hypercholesteremia, cardiac-related problems. This population was not necessarily consulting a doctor. So I went into the medical correlation, and I realized that a doctor was absolutely essential, since factors such as hypothyroidism, arthritis contributed to obesity in a large way, hormones, estrogen, the entire endocrine structure, medications, birth control pills, steroids, all of these played a role in the medical management of obesity. And as a consequence, I was delighted with our speaker today, Dr. Hala. Now, Dr. Hala did her master's in medicine in 1987 and her MRCP from the UK in 1999. She went on to do her SCE in endocrinology and diabetes in 2011 with vast working experience of 30 years in Egypt, Kuwait, and the UAE. The interesting connection: Dr. Hala deals with endocrine disorders. She deals with pregnancy, diabetes, etc. during pregnancy, hypertension, dyslipidemia, obesity, thyroid disorders, pituitary disorders, adrenal disorders, polycystic ovary syndrome. We could have no better speaker today to talk to us about obesity, a health syndrome from the medical management perspective. Ladies and gentlemen, I leave you in the experienced hands of our head of department endocrinology, Dr. Hala.
Thank you very much, sir, for this. And I hope our talk today about obesity as a health syndrome You can see my slides now?
Yes, we can see your slides, Dr. Hala.
Okay.
Dr.
Good morning,
Wilco.
everybody. Our talk today about obesity as a health syndrome. What is the definition of obesity? Just a minute, please. Yeah. So our definition of obesity, overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. This issue has grown to epidemic proportions, with over 4 million people dying each year as a result of being overweight or obese in 2017, according to the Global Burden of Disease. In 2015, roughly 604 million adults had obesity worldwide. And since 1980, the prevalence of obesity has been doubled. The prevalence of obesity increased the greatest from 1980 to 2015 for males ages 25 to 29 in low to middle income countries, from 11.1 to 38.3%. A new analysis of the body mass index of the United States indicated that by 2030, 1 in 2 adults will be obese. Imagine 1 in 2 adults will be obese. It is suggested that all adult patients be screened for overweight and obesity by measuring their body mass index as part of their routine physical examination. It is also recommended to measure the waist circumference in those with BMI between 25 and 35 grams per square meter. Without screening, many high-risk patients may not receive counseling about health risks, lifestyle changes, and risk factor reduction. The body mass index was developed as a risk indicator of the disease. It is the person weight in kilogram divided by the square height in meters. And according to the body mass index, we can assess whether this patient is obese or overweight. So obesity, if his body mass index is more than 30, and the normal weight from 18.5 to 24.9, overweight from 25 to 29.9. And obesity is classified into 3 classes. Class 1 obesity from 30 to 34.9, 35 to 39.9, class 2 obesity, and class 3 obesity is more or equal to 40. As you spoke about the cause of obesity, it is overeating or lack of exercise, environmental factors, pregnancy, family history, medications, genetics, hormones. There are potential causes of obesity. Internally, the hyperreactivity of the food cues. When you see the food, you are over salivation, hunger pains, heightened the hunger response, delayed fullness, eating, and still you didn't feel that you are full. Chronic inflammation, genetics, gut microbiota. Also externally, the availability of the high caloric foods and the large portion size, always saying combo and with less price, and the people are eating more and more. More sedentary life, less physical activity, and also stress. What we mean by the poor diet? Obesity doesn't happen overnight. It develops gradually over time as a result of the poor diet. Eating large amount of processed food and fast food, high in fat and sugar, eating large portion than you need, drinking too many sugary drinks, and the comfort eating, as having stress or depression, you eat to make yourself feel better. It may be true that genetic traits can be inherited, such as having large appetite, which makes losing weight more difficult, but it certainly does not make it impossible. Obesity is more to do with environmental factors, such as poor eating habits during childhood. Because of that, the family is responsible a bit part in obesity in their children. We advise them to give him a gift as a fruits instead of chocolate, instead of juices. And also there are rare genetic conditions as Prader-Willi syndrome. Medications have to be ruled out at this cause of obesity, as corticosteroids, some medications of diabetes mellitus as sulfonylurea, and epilepsy, some antipsychotic as in schizophrenia. Also diseases have to be ruled out, and it is not a secondary cause of obesity, as in underactive thyroid gland, hypothyroidism, Cushing syndrome, in which it is a disease that causes overproduction of the steroid hormones. There is in obesity hormonal imbalance occurring, and neurobiological mechanisms are reported to contribute to eating in the absence of energy demand and hunger. So the patient is not hungry and still he wants to eat. The gut hormones play the most critical role in obesity. The cells of the gastrointestinal tract sense the ingested food and release the gut hormones that regulate energy and glucose homeostasis, as the glucagon-like peptides, and the peptide tyrosine, and the oxyntomodulin signal the availability of the nutrients into the brain and suppress the appetite. And because of that, the new anti-obesity drugs rely on these hormones. Also, we consider not only the GIT, but the adipose tissue. The visceral fat and the adipose tissue act as an endocrine gland, secreting leptin. And this leptin, which is secreted by the adipose tissue, acts as a signal for energy availability and promotes satiety, and the patient is full. In the absence of food, ghrelin, it is secreted from the stomach and sensitize the brain to the intake of food. So when we feel hungry, this is because of hormones. If we feel full, also because of the hormone secreted. So the high caloric intake leads to adipocytes, which is the fat tissue, hypertrophy and hyperplasia, reduce the blood supply and causing hypoxia, macrophage and cell infiltration, necrosis, and secretion of the adipocytokines. This leads to localized inflammation in the adipose tissue and overall systemic inflammation. And as we see here, the GIT, which acts secreting the hormones, and also the adipose tissue or the fat tissue in the visceral adiposity, which also secretes hormones. So if you eat the glucagon-like peptide, the amylin, it's secreted to the blood, going to the brain, and it is called the anorexigenic signals. That you mean you feel full, you don't feel hungry. And then also, if you are no food, then the ghrelin is stimulated, going there, and it is the anorexigenic signals. Also, the adipose tissue secretes the adiponectin and the leptin. And if the leptin is secreted, usually going to the brain, and you feel that you are full. So what happens in adiposity and increase the obesity and increase the visceral fat, that the leptin is increased in amount, but it doesn't go to the brain in sufficient amount, so you don't feel full. Why it doesn't go to the brain? This is called the leptin resistance. And why this leptin resistance? That there is a blood-brain barrier which doesn't allow the leptin, which is in high amounts, to pass and go to the brain, so you don't feel full. Obesity is the most common risk factor of metabolic syndrome, which, if not checked on time, puts you at the risk of type 2 diabetes, heart disease, and heart attack or strokes. Metabolic syndrome is measured and defined if three things are present in the person. The waist circumference is increased more than 40 inches in males and more than 35 inches in ladies, with one of the following. Two of the following, you will be defined as metabolic syndrome. Fasting sugar more than 100 milligram, triglycerides more than 150 milligram, the high density lipoprotein less than 40 in men and less than 50 in females. So with blood pressure more than 130/85, any two with the waist circumference is defined as metabolic syndrome and puts you at the risk of more diseases. If the body mass index is more than 30, and this is the class 1 obesity, then you are more prone to have hypertension, myocardial infarction, heart disease, congestive heart failure, and strokes. If we have two persons and both are metabolically healthy, they don't have high cholesterol, no hypertension, no type 2 diabetes. One of them normal weight, the other is obese. Then the cardiovascular incidence is 96 increased in the obese person with the risk of heart failure, 7% increased risk of cerebrovascular disease, and 49 increased risk of coronary heart disease. The liver also is affected in obesity, and the non-alcoholic fatty liver disease is found more in obese persons. And now the new term of this non-alcoholic fatty liver disease is the metabolically associated fatty liver disease. Also, the adipose tissue is contributed, the visceral adipose tissue secreting more leptin, causing and more free fatty acids is present, tumor necrosis factor, all these causing the simple steatosis. 10% of these patients will have the non-alcoholic steatohepatitis, and 8 to 26% will develop to cirrhosis and then to the hepatocellular carcinoma. Obesity is a risk factor for several chronic diseases, most notably hypertension, type 2 diabetes, dyslipidemia, chronic heart disease. In addition, obesity has been shown to constitute a risk factor for colon cancer, postmenopausal breast cancer, endometrial cancer, renal cell cancer, as well as adenocarcinoma of the esophagus. Yes, obesity and diabetes are linked, and patients who are overweight or obese, they are needed to screen for type 2 diabetes. Even if they have no family history of diabetes. Obesity is the main modifiable risk factor for type 2 diabetes. That means that if you lose weight, your diabetes will be improved. As the body mass increases, so does the risk of type 2. People with severe obesity are particularly at risk of type 2 diabetes, and you have to screen for it. Having a large waist circumference increases the likelihood of developing type 2 diabetes. So as we see, the comorbidities with obesity, type 2 diabetes, hypertension, dyslipidemia, cancer risk, mood disorders, depression, heart diseases, reproductive disorders as polycystic ovary syndrome in ladies, hypogonadism in males, liver disease, fatty liver disease. And we see that improvement and substantial weight loss can improve all these complications. 5% can improve your sugar and diabetes. Hypertension, 15% will improve your hypertension, dyslipidemia, sciatic liver disease, sleep apnea, osteoarthritis, stress incontinence, gastroesophageal reflux, polycystic ovary syndrome. Ladies with polycystic syndrome and having irregular menstruation and more hirsutism and acne, if they lose 15% of their weight, their periods become regular, their hirsutism improved. The goal of our therapy for obesity is to broadly prevent, treat, or reverse its complications. Initial weight loss treatments focus on lifestyle interventions, including healthful nutrition, increased physical activity, and behavioral modification. For individuals not achieving the desired weight loss, medications are often considered before more invasive weight loss techniques are considered. Whatever medical or invasive procedure, still the pillar, and it should be continuous, is the healthful nutrition, increased physical activity, and behavioral modification. And without it, even with bariatric surgery, the recurrence will be high. Behavioral therapy is considered to be the essential component of managing the patient with overweight or obesity. The goals are to help patients make long-term changes in their eating behavior by modifying and monitoring their food intake, modifying their physical activity, controlling the cues and stimuli in the environment that trigger eating. We always advise the patient, think before you eat what you are eating and why you are eating. Are you really hungry or not? 3 to 5% weight loss improve the blood pressure, the lipids, the glycemia, and the liver steatosis. 9 to 10% improve your liver necrosis and inflammation. And more than 10% will reduce your cardiovascular risks and a variety of inflammatory conditions. But still, if the body will allow you, the isolated caloric restriction stimulate a protective response to defend the desired fat mass. This response is called the metabolic adaptation. And usually the patient loses some weight and then a plateau. Why the plateau? Because the body tries to protect its fat mass. It includes increased appetite and decreased energy, increase the food focus or obsession, increase the hunger, decrease satiation and satiety, and decrease the thermogenesis. It is mediated by changes in the multiple gastrointestinal and CNS peptides, increase the ghrelin, which decrease the peptide, tyrosine, and the cholecystokinin and amylin. So the body also tries to conserve its fat. And because of that, many patients, when they are taking the medication and so on, they come to a plateau because their body refuses them to lose more. For patients who are unable to achieve the weight loss goals with a comprehensive lifestyle intervention alone, options include pharmacologic therapy, the use of medical devices, or bariatric surgery. So we have to evaluate the presence or the absence of the adiposity-related complication and their severity, as metabolic syndrome, prediabetes, type 2 diabetes, dyslipidemia, hypertension, cardiovascular disease, fatty liver disease, polycystic ovary, infertility, hypogonadism, obstructive sleep apnea, osteoarthritis, asthma, urinary stress incontinence, gastroesophageal reflux, mental depression. And we start first, as we said, with the lifestyle therapy. The patients more than 30 and they didn't get the desired weight loss, then we can start the anti-obesity medications. For patients, BMI more than 27 with a morbidity, with a other severity of the complication, we can start also the anti-obesity medications. And if these are failed, then more invasive techniques will be done. So it can be, the drug therapy can be considered for those with a body mass index more than 30 kilogram per meter square, or a BMI of 27 to 29.9 kilogram per meter square with weight-related comorbidities, who have not made the weight loss goals. The loss of at least 5% of the total body weight at 3 to 6 months with a comprehensive lifestyle intervention. If they cannot reach it, then we can try the drug therapy. The FDA approved for the long-term use since 1999. First was the orlistat. It was only intestinal lipase inhibitor, which reduced the fat absorption. And then started medicine, which act on the brain, as the phentermine topiramate, the Contrav or the bupironone latroxone in 2014. And the first time they start the glucagon-like peptide 1 receptor agonist, which is called the liraglutide 3 milligram, which is Saxenda. Then they come on 221 with the Wegovy or the semaglutide 2.4 milligram. It's also a glucagon-like receptor, but it is taken once a week, which decreased the appetite, increased the fullness, and increased the satiety. And the weight loss here comes to 12.4 of their body weight. So first, it was a small amount loss of their body weight, 3.8, then 8.6, and then we see here at 12 reaching 12.4. The Food and Drug Administration also on 8 November 2023 approved the tirzepatide Zepbound, which is sold here in the name of Mounjaro, to be the most recent approved anti-obesity drug. And it is said that it loses up to 20% of their body weight. And also it is taken once a week. Bariatric surgery, if the patient doesn't also respond to the pharmacologic therapy, then bariatric surgery includes the gastric bypass, sleeve gastrectomy, gastric brain, duodenal switch. These operations have proven results in treating class 3 obesity. They also help normalize metabolism, including blood sugar, blood pressure, and cholesterol. And the new patient selection for these operations now recommends metabolic and bariatric surgery for individuals with a BMI of 35 or more, regardless of presence or absence or severity of the obesity-related condition. And it will be considered for people with BMI 30 to 34.9 and metabolic disease, as diabetic or hypertension, and in appropriately selected children and adolescents. How these bariatric procedures act, what is the mechanism, how they affect our weight loss? It's through 3 fundamental mechanisms: malabsorption, restriction, and the neurohormonal response. First, they do the vertical banded gastroplasty and the laparoscopic adjustable gastric banding, and they only restrict it. They restrict the amount of food intake. They cannot eat more, and limit the solid food intake by restriction of the stomach size as the only mechanism of action. And these procedures have largely been abandoned now. The laparoscopic sleeve gastrectomy has become the main restrictive procedure. It is more successful due to its hormonal effects on the hunger control, because they remove part of the stomach, and the stomach, as we know, secretes the ghrelin, which is the hunger, so the patient doesn't feel hunger. There are combination of the restriction and malabsorption established procedures, such as the roxangastric bypass. And the ghrelin is a peptide hormone secreted in the foregut, stomach, and duodenum that stimulates early phase of milk consumption. The normal pulsatile release of this oxygenic appears to be inhibited in the gastric bypass patients. Also, it is being observed, as we said, in the laparoscopic sleeve gastrectomy. There are types of the bariatric surgery. The Roux-en-Y gastric bypass, which is very common, the biliopancreatic diversion also, and the vertical sleeve gastrectomy are shown here. So also the hormones, such as the GLP-1 and the cholecystokinin, which are increased after this bypass operations, may promote an anorectic state. So because of that, these operations are more losing weight. We have the gastric balloon. The gastric balloon is an inflatable medical device for reduced weight. The gastric balloon inflatable medical device that is temporarily placed onto the stomach to reduce your weight. The weight loss mechanism here of the intragastric balloon is by restriction and likely by change in the gut motility. Any balloon with a volume of 400 or greater can induce satiety and also causing a delay in the gastric empty. Intragastric balloon therapy is an option for patients with a BMI of more than 27 per meter square in Europe or 30 kilograms per meter square in the States. The intragastric balloons are capable of producing from 6 to 15% total body weight loss compared with 1 to 5% total body weight loss through lifestyle intervention. Although intragastric balloons are safe and effective in managing obesity for short term, they are temporary measure and weight regain is expected after their removal. There are some therapies that we do not recommend. Liposuction. In liposuction, although waist circumference and plasma leptin were significantly decreased, but no improvement in the insulin sensitivity of the muscle, liver, or adipose tissue. Liposuction did not alter the plasma concentration of the inflammatory markers at the CRP, interleukin-6, tumor necrosis factor, or adiponectin. And there were no significant improvement in other risk factors for coronary heart disease, blood pressure, plasma glucose, lipid, or insulin concentration. Our aim for the bariatric surgery or the treatment of the obesity is to treat the complication, to prevent them by improving them, improve these risk factors. The liposuction didn't help us in this issue. Human chorionic gonadotrophin, it does not induce weight loss or fat redistribution, nor does it reduce hunger. And there is no evidence that with this treatment is effective in the treatment of obesity. Dietary supplements. We advise against their use because evidence to support their efficacy and safety are limited. Examples like the ephedra, green tea, chromium, chitosan, vitamin B12, guarga. Acupuncture. Acupuncture has also been studied for the treatment of obesity. Most studies have been uncontrolled trials, and results from some, but not all, controlled trials have shown modest benefit of acupuncture for weight loss. However, the majority of these controlled trials are small, of short duration, and do not include adequate placebo controls. Our recommendation is to screen all adults for obesity. Offer or refer patients with a body mass index of 30 or greater to intensive multi-component behavioral intervention. A 5 to 10% weight loss can reduce the risk of heart disease, diabetes, and should be encouraged for all patients who are overweight and obese. And we consider pharmacotherapy in adults who have not been able to lose weight through diet and physical activity alone, and who have BMI of 27 kilogram or greater and obesity-related comorbidity, or BMI of 30 kilogram per meter square or greater. Some patients come to my clinic and their BMI is only 25 or 24, and they are asking for pharmacotherapy and drug medicine to lose weight. And this is not an indication. Consider the bariatric surgery in adults who have not been able to lose weight through diet and physical activity alone. And according to the new recommendation, BMI of 35 can do it, and more than 30 if they have comorbidities. Regardless of the body weight or weight loss, all patients should be encouraged to be physically active for improved health and weight maintenance. At the end of my talk, I want to add, this is a lifelong journey. Think of obesity as a complex, multifactorial chronic disease, like hypertension, like type 2 diabetes and dyslipidemia. So it needs long-term, not only to lose weight and then return back to your bad habits of eating. No, it is lifelong journey. Thank you.
Thank you. Thank you.
Thank you.
That was put in such simple language, such a complex subject in such simple language. And your key practice recommendations at the end were absolutely clear. Behavior change, pharmacotherapy, and bariatric surgery. And in the appropriate, acceptable manner of above 30 BMI for pharmacotherapy with comorbidities and above 40 BMI with comorbidities. You explained bariatric surgery so simply that it becomes absolutely clear. Ma'am, you made the path clear for individuals who are obese. We have 18,000 participants in this series of weight loss challenge this year, and this information is absolutely enlightening to all of them. And to me, of course, and to me, it's a medical subject, and so clearly and simply explained. We are grateful. We are truly grateful. Thank you, ma'am. But I will pass this on to Dr. Wilku, who will ask the questions that I do not have the knowledge to ask. Yes, Dr.
Yes, sir, but I want only to emphasize that who are with us in this webinar, that it's not only, and in this competition, that's not only the 3 months, but they should continue it for life, as I said. It is a lifelong journey, not only for 3 months for the competition. This is not our aim. Our aim is to maintain it for life.
We will heed your statement very seriously, Dr. Hala, and we will continue doing whatever we can with your blessings and support for the rest of the year, I assure you. Thank you so much for this suggestion. Dr. Sir.
Yeah. Thank you, Professor. First of all, thank you, Dr. Hala, for a wonderful presentation. You have covered, like Professor said, each and every point and aspects of weight loss and obesity management. Perfectly, very much enriched knowledge we have gathered today. And those who have not attended, they can see the video. It's a wonderful presentation. But still, there are many questions like I was going through. As soon as you were mentioning some points and questions were popping up in the WhatsApp and the chat box also. Mr. Sarfraj has asked the first question. Like you mentioned about the pharmacology for weight loss management, he's asking, is taking medicines like fat burners and hunger depressants good for weight loss? And he has second question, like you mentioned about the new medicine Munjaro, which has promising for weight loss. Is it good for weight loss, or is there any side effects?
For Monjaro, of course, it is a very good medicine, but it has some side effects as the fullness, sometimes GIT problems happens as severe diarrhea or abdominal pains. We have to stop it if it is very severe side effects. And also the problem with it that when to stop it and how to stop it. We don't have much studies. The last study said it's after at least 2 years to take it, and then slowly they stop it because obesity and weight gain may regain again. So it is a lifelong medicine up till now. And this is also a great problem.
Yeah. There is another question I was wondering about, because last three, this is the fourth weight loss challenge event we are doing. And every time we come across one advice by the gym trainers and personal trainers in the gym about some injections, people were not able to identify, but some of them came up and we were studying into it also. Like Madhurima has asked, some gym trainers advise HCG, the human gonadotropin, medication for fat loss. Is it safe?
No, it
Because
is not
you
safe.
know HCG, HCG is
It is not safe
basically
and
used
not FDA approved for weight loss.
true. But the gym trainers are frequently advising this. I don't know who is going to control on them, but it's not suggestible. But people do, and they fall into a bad trap later on. So you suggest it's not good, it should not be taken.
No.
Correct. Okay. Third question. Anshuman Singh, he has asked, my BMI is 31.5. I do not have any family history of medical problems. Am I at risk of developing diabetes? You already
Yes.
mentioned about that.
Yes, he should screen himself for, because any obese person may have a risk to develop type 2 even if he has no family history. Because he is considered, if we measure his waist circumference, he will be more like metabolic syndrome.
True, true. So even if you don't have any family medical history or any of medical history for yourself, and you are more than 30 BMI, you should be having a good screening for yourself, and you should be aware of your exact health and take a consultation from the doctor.
Not only for
Mr.
sugar, but also for cholesterol and for liver, because he have more liable to have liver disease as fatty liver or dyslipidemia or sugar.
True. Mr. Ubaid Ahmed has asked, like we were talking about Monjaro. He's asking, is it available in UAE? Of course, it is
Yes, it is
available,
available,
but
but the amount, or usually because there are great demand on it. So this is another problem, that this is not always present.
so my point of suggestion will be, ma'am, do you think it should be not taken as OTC? It should be consulted by a doctor, completely have a medical checkup whether you suit for this
Yes,
or
because
not.
we have to
And
rule out any history of
yeah,
pancreatitis, any history of medullary thyroid carcinoma, and we should follow the patients. Some patients are taking very quickly and very high doses, and then they stop it, and then they regain the weight quickly. So it is not advisable to be by the patient itself.
before starting, it's best to have a consultation with the doctor, and let the doctor decide what dose and whether he suits or not. Okay. Uh, You have spoken about liposuction. In the morning I got a message in the WhatsApp. Liposuction is also becoming popular. Many health clinics, who the wellness clinics and health clinics, they are promoting liposuction for a faster weight loss. So you spoke about liposuction also. So is it beneficial?
For the shape, yes, but for the we are not only treating the shape of the person, we are treating him to protect him from the risk factors. So it doesn't help in insulin sensitization, and it doesn't reduce the risk of diabetes or heart attacks or strokes. But bariatric surgery or these medicines like Monjaro, they reduce the incidence of these problems. And this is our aim, health, not only to lose weight. We lose weight to protect your health. This is the point, not only the shape.
Yeah, true. Mr. Obez has asked another question. Okay. Uh, can you tell me if thyroid issues are also a reason for the weight gain?
Yes, of course. If the thyroid is not acting properly, hypothyroid, this means lazy thyroid, then you gain weight. If you correct your thyroid, then you easily to lose the weight.
True. And ma'am, there was one participant on the first day of event where he came and heard about balloon therapy. You spoke about that also. So actually, he was planning to go for a balloon therapy because he was very much worried about his weight. His BMI was 40 plus, and he was a little hesitant of bariatric surgery. But he thought of, because he tried all the lifestyle medicine and other alternative medicine, whatever he could do, he did it. Then he thought, okay, I will not go for a cutout surgery and anything under the blade. But he heard about balloon therapy. So, what do you go suggest? You have already spoken about it. So now
Yeah,
there are few ingestible format of balloon therapy also.
yeah, they're ingestible and then they dissolve after 6 months in your body without getting out. But the problem that it is only acting as a restriction. So they only limit the food, no hormonal effect on this. And then because of that, when it is finished, the short term, you will regain the weight quickly. It is not for long term. So sometimes they do it and then they add medicines after that, or they do the operations after that. But only then they will regain the weight quickly again, very short term.
True. The last statement you made, it's a lifelong journey. You have to maintain your health throughout the life. It's not that for a particular moment you are doing a weight loss and again you leave it, again it comes back the faster way. So, what do you in last one sentence? What do you suggest? What should be the format of weight loss? Starting with the lifestyle therapy, then going for a regular checkup for any comorbid condition, then if required let the doctor decide for any pharmacology intervention, or doctor will suggest if there is any problem for a bariatric or surgical intervention. What is your statement?
The medical nutrition and the lifestyle changes and the behavior therapy in the 3 stages, it should be continued. This is mandatory. But many patients try to lose the weight and they even doesn't lose 5% of their body weight after 3 months with proper food and so on. If their body weight index is more than 30, then we may consider the pharmacotherapy. And also the pharmacotherapy without the food intake properly, choosing what food you are taking, it may not be effective. It is not always effective. And also it is individualized. Some patients, even they are taking the weekly injections, they doesn't lose the proper weight we needed. At that stage, then bariatric surgery will be advised.
Yeah, all three
So it is
stages.
it is a difficult task. And always I tell my patients to lose weight is not an easy task. It is really a very difficult task.
True, true, true. I received one more question. The patient is, the participant is from Dubai, and he's insulin dependent diabetic for last 14, 15 years. And his BMI is 33.5. And he has many comorbid conditions like his blood pressure is fluctuating. He has knee pain while doing some exercises. And what do you suggest for him?
You can start for him the anti-obesity medications.
He's on insulin. He's taking 20 units in the morning and 12 units in the night.
But this is usually not insulin dependent. Maybe secondary failure or type 1 diabetes or type 2. Which type?
Because he started only 14, 15 years back. So
How
better,
old he is?
yeah, so consult an endocrinologist for a proper assessment and
Yeah,
advice.
to know which type first, and then we can assess.
Yeah. From my side, thank you very much, Dr. Hala. Professor, over to you.
Thank you very much.
The wisdom of experience, the wisdom of experience. Questions were asked on HCG, hormone therapy, balloon therapy, liposuction. And Dr. Hala, you so comfortably and confidently answered those questions and gave us of your wisdom. Thank you so much once again, not only for your talk, but also for your extempore answer to the questions that vex most of us all the time. Thank you so much, Dr. Hala.
Thank you, doctor. Thank you very much.
Dr. Wilku, thank you, sir. Clever questions. It takes an intelligent person to ask a clever question. Thank you so much for your support in enhancing the value of the webinar by asking questions that are on top of all our minds, but we do not have the courage to ask those questions. Thank you so much. My colleagues in the back end, the IT department, RAK Hospital, and my very own Arabian Wellness, thank you so much for your hard work in putting these webinars together. Now, I must tell you that as a consequence of Dr. Hala's talk, while we will have many more discussions on the lifestyle aspect, I would request Dr. Wilku to definitely give us one session at least on bariatric surgery, on the surgical aspects of weight loss. Remember, we have a community of about 18,000 individuals with us at this point of time. All of them are overweight. Most of them have above 30 or even 40 BMI. This type of information would be very, very helpful. You can see that our next webinar will be on the 2nd of Feb, and I look forward to seeing as many of you at that webinar as I would love to have. Thank you so much and good day.